Dr. Bore.
Dr. Bore, okay.
Yes, our presentation is going to be on corneal ulcers.
Recording in progress.
I'm a cornea and anterior segment specialist. So as we continue the class, you'll get to know what the cornea and anterior segment is, and we'll get into the introduction, the causes of corneal ulcers, how to treat it, and the complications. So if you have any questions, you can just type them in the chat box. Then once we finish, in case you can at least moderate the questions. So this is an image of the human eye. So when you look at it, the eye has the eyeball has the outer coating. So that's we have the posterior 2/3, which is this white part covered by the sclera. Then the anterior 1/3 of the eyeball is covered by the cornea. So that's what provides the protective outer coating for the eyeball. So when you look at someone's eye, you'll see a clear glass-like structure at the front part. This is what is called the cornea, and that's what we're going to discuss today. So the anterior segment is any part in front of the iris, which is this, and the lens structure. So this whole anterior part is called the anterior segment. The posterior part is what we'll cover later. So corneal ulcers, the reason we are so careful about corneal ulcers is that it's a leading cause of blindness because they heal with corneal scars. So if you look at this image, this picture of a young lady, you can see both eyes have corneal scars and with blood vessels flowing into the scars into the scarred area. So the scarring can be prevented by proper treatment of the corneal ulcers. This is another photo of a young child. When you look at the left eye, you can see this obvious haziness and opacification of the cornea. The right eye looks clear. You can see the pupil clearly and the reflex from the posterior part of the eye. So when you go to the clinic, the anterior segment clinic, make sure you're able to ask questions and find out how you can differentiate a corneal scar, this like the anterior opacification, and cataract, because that's something simple which you should be able to do. This lower image is also of an old man with a corneal scar. I don't know if you can see it, but if you look clearly, you can't see the eyelashes for this patient in both eyes. It's like the eyelids have turned inwardly, and that is what is leading to scratching of the cornea by the lashes. That's trichiasis and entropion, possibly due to trachoma, leading to the scarring of the anterior part of the eye. That's the cornea. So the only treatment for corneal scars is to do a corneal graft. So what happens is that as surgery is done, the part which is scarred, the anterior part of the eye, the cornea, is excised. Then a graft is put in place and sutured. So if you look here, you can see there's, I don't know if you can see it clearly, but there's this circular part. That's the graft. Then there are 16 sutures on the cornea to keep it in place. So this is the only treatment we have for corneal scars. And the thing is with grafts, as you might know, is that you can't guarantee that it's going to be there for a lifetime. The patient has to be on medication, steroids for a long time to suppress the body's reaction. And later on, you can find the graft fails. So it's always good to try and just prevent it coming to this stage. So we'll go through the layers of the cornea so that you know the structure which we're handling today. So the cornea has 6 layers. This diagram only shows 5 layers, but it has 6 layers. So this is the epithelium, the outermost coat of the cornea, which is underlying it. You have the Bowman's layer, which is a strong structure, which protects the other layers. The stroma is where you have hydration of the eye. And when the epithelium is not intact, this layer, it has tight junctions. So when it's not intact, when you put fluorescein stain to diagnose your corneal ulcer, it's taken up by the stroma, this layer. The Descemet's membrane and the endothelium. This endothelium has the sodium-potassium ATPase pumps, which pump out fluid from the stroma. And that also helps to make the cornea stay clear and compact. So just remember there are 6 layers. We have the Doer's layer. which is between the endothelium and the descemetes. That's not here. It was something which was discovered a few years back. So when we look at the causes for corneal ulcers, it can either be infectious or non-infectious. Infectious causes are bacterial, viral, fungal, and it can also be because of ACANTHAMOEBA. Non-infectious causes it can either be due to trauma. The most common cause is the chemical burns, which is also here, just in the third bullet point. Then you have traditional eye medicines, exposure keratitis, vitamin A deficiency, corneal anesthesia, and others such as Mooren's ulcer. So, like I had mentioned when I showed you the histological section of the cornea, if you want to diagnose let's start from the history first of all. All corneal ulcers are painful because when the epithelium is not intact, you have exposure of the corneal nerves. The cornea is very highly innervated. So if the epithelium is not intact, the nerves become exposed. The patient complains of a lot of pain and foreign body sensation. Then there's also photophobia and tearing. And like I said earlier, when you looked at the histological section, when the epithelium is not intact, that's what we call a corneal ulcer. And so this is fluorescein. You can see this is a fluorescein strip. You put local anesthesia on the strip, put the strip into the eye. Put the strip into the eye, and the ulcer takes up the stain. So any area where there's an epithelial defect, this whole area, it takes up the stain. So when you look at it with a cobalt blue light, it's usually very, very clear. So if you're in a setup where you're able to get access to the fluorescein staining and a patient comes in complaining of painful red eyes, always stain the eyes and check what is there. So like I said, it's essential to stain red eyes with fluorescein and start specific treatment as quickly as possible and refer the patient to an ophthalmologist. So bacterial corneal ulcers present with red eyes, purulent discharge, and if you look at this image, this is what is called a stromal infiltrate. It's like having a collection of pus within the stroma. So, and if you look into the eye, you can shine a torch and you'll see that there's a collection of pus in the anterior chamber. So just imagine that you have the cornea at the front, the glass-like structure. Then behind it, you have the iris and the lens. And between the two, there's a space. That space has aqueous humor normally. But in this case, because of the infection, you have some of the aqueous humor being replaced by pus. So that's what is called a hypopion. So you need to know the difference between a hypopion and a hyphema. A hyphema is when you have blood in the anterior chamber. Hypopion is a collection of pus. So if you shine a light from the side, you'll see that there's the space between the cornea anteriorly and the iris and the lens. And you'll see that the light sort of like passes behind this infiltrate. So that's how you'll be able to tell that it's something which is on the cornea and not on the lens. So when you're in the clinic, try and do that. Try and shine the light from the lateral aspect and see it passing through the anterior chamber so that it helps you to tell where the cornea is and where the lens is. So this is just the same thing. This is a stromal infiltrate or a stromal abscess. Then within the eye, you can see the collection of pus. So if you're told to describe this eye, always start from outside going inwards. Start with the eyelashes, which are not being seen here, but if there was discharge, you describe it. Then you can see that the eye is very red. Then on the cornea, there's this infiltrate or an abscess. Then there's the hypopion, the collection of pus. Then if you can see posteriorly here, the pupil is dilated, not very dilated, it's mid-dilated, and the lens looks clear at the back. So the reason I'm saying the lens is clear is because you don't see anything white. It just looks like a black space there. So that's why I'm saying the lens is clear. This is another image of an eye with an infection. So like I said, you always start from outwards going inwards. You start with the eyelids. The conjunctiva is very injected. It even looks swollen. That's chemosis. The cornea, we have an infiltrate here. And again, a hypopion. And I don't know if you can see it, but the pupil is dilated. These are the margins. This is just a reflex, a light reflex from the whatever you're using to examine the eye, whether it's a torchlight or the slit lamp light. So this one, you can see when you look at the eyelids look swollen. There's a purulent discharge in the medial canthus. So this is the medial canthus, this is the lateral canthus. So the medial canthus, you have the collection of purulent discharge. The eyelashes are matted together and they have discharge. The conjunctiva is injected, meaning that it's red, hyperemic. Then you can see there's the infiltrate here, hypopion again in the anterior chamber. And I think this will be hard to see, but you can see the pupil posteriorly. These are light reflexes. This is the infiltrate. And this one you can see here with a level is the hypopion. Again, you have crusting on the lashes, discharge. And then in this case, you can see you can't see the cornea at all. So in this case, the infection has really damaged the cornea. You can see there's a perforation here. So in such a case, if you put fluorescein and look at it through cobalt blue light, you'll see like fluid flowing through that area. So the area where the fluid is washing away the fluorescein will appear dark with the blue light. So you're able to pick leakage from the eye using the fluorescein and the cobalt blue light. If I'm moving too fast, can you tell me? So when you're investigating a patient who has a corneal ulcer, you need to do corneal scraping. So we normally use a blade. You put local anesthesia and you take a sample from the cornea. We take this sample for microscopy, culture, and sensitivity. So in the meantime, after you've done that, the patient needs to be on cycloplegics. This helps to relax the eye muscles and dilate the pupil. So this relieves pain. Examples of cycloplegics are atropine and cyclopentolate. Then you start the patient on an antibiotic cover. So it should be very frequently for the first 2 to 3 hours, that's every 10 minutes. And then after that, the patient should instill it hourly and you refer the patient. So examples of antibiotics which can be used once you're starting the treatment, let's say you're in the periphery, you can use things like ciprofloxacin or floxacin. Start it every 10 minutes for first 2 to 3 hours, then hourly. And also cover with atropine twice daily or cyclopentolate 3 times daily and refer the patient immediately. Anytime you're prescribing any eye drops, you tell the patient to instill only 1 drop. It should not, the tip of the bottle should not touch the eye so that you keep it clean. And if they're putting 2 different types of medication, there should be a space of 5 minutes between the 2. They should not put everything together at the same time. So just remember that you get a patient with a red eye, stain the eye if you have fluorescein. If you see an epithelial defect, or if you shine your torchlight and you see something white on the eye, and you've also shown your light from the lateral aspect and you've seen that it's on the cornea, you're better off just starting the cycloplegics. That's atropine or cyclopentolate. Start the antibiotics and refer the patient immediately. So we'll also look at herpes simplex ulcers. So they can either be dendritic or geographic or amoeboid. So if you look at this, this is a slit lamp photo, which is taken under cobalt blue light. The eye has been stained with fluorescein. So if you look at this, you can see there's a defect on the cornea. There's a defect on the cornea, and it has a dendritic pattern. So there's a difference between eyes which have herpes simplex infections and herpes zoster, if it's an epithelial ulcer, and an corneal ulcer. The simplex ulcers have rounded edges. They look like it's budding. But when you look at one for zoster, they have tapered edges. So at the end of each like projection like this, you'll see like it looks like a bud. That is herpes simplex. But when it's tapered, that's zoster. So if this is left to progress, it will take this shape. So it becomes a geographic or amoeboid ulcer. So if you see any patient and you stain, you put fluorescein and you examine and you see that it has this pattern, then it's a viral ulcer. That's herpes simplex. This is the same thing. You can see this, it has taken up the fluorescein stain. You can see pulling of the fluorescein stain here. If you look at the cornea, you can see an ulcer with a dendritic pattern. This is the dendritic pattern. I hope that's clear. So if in such a patient as small as it looks, if you put steroids, because you see most patients go to pharmacies, they complain of painful red eyes. The most common drug they're given is Probita-N. Probita-N has a steroid. What happens is that the ulcer will become amoeboid, to become geographic or amoeboid. Then the next thing that will happen is that the eye will perforate. You can see in this case, there's an ulcer, an infiltrate here. This place, as you can see, it's thin and it looks brownish. That means that the eye has perforated, and now the iris, because now there's no protective outer coating, the iris is pushing out. So any patient with a painful red eye, if they're on steroids, stop them immediately, start antibiotics, refer to an ophthalmologist. Then we'll discuss herpes zoster ophthalmicus. So it's because of endogenous recurrence of chickenpox, that's varicella zoster virus, and it affects the trigeminal division of the ophthalmic division of the trigeminal nerve. So if you look at the distribution of the lesions, you'll see that it respects the dermatome. It will not pass the midline, and it will affect, as you can see clearly, it just affects the ophthalmic division of the trigeminal nerve. And what happens is that if it comes to the tip of the nose, like in this case, if you see any lesions on the tip of the nose, just know the eye must be involved. Even if the eye is swollen, covered up, you can't see it well, if you see the tip of the nose is affected, just know that the eye is affected. That's because the tip of the nose is supplied by the nasociliary nerve, which also supplies the interior of the eye. This is known as the Hutchinson's sign. So any patient you see with HZO who has lesions, again, I repeat, on the tip of the nose, or just to be on the safe side, always refer these patients to the ophthalmologist. After you started the treatment for HZO, refer the patient. So let me just take you back. If you see a patient with such an ulcer, you need to start them on acyclovir ointment 5 times a day and refer them to the ophthalmologist. But in the case of HZO, you always need to start the patient on both the ointment and systemic antivirals. So you'll start the acyclovir ointment 5 times a day, and also start acyclovir tablets, 800 milligrams, 5 times a day for 7 days. In some cases, we'll give it for 10 to 14 days. But once you start this treatment, plus cycloplegics, refer the patient to an ophthalmologist. So this is a patient who previously had HZO. As you can see, you have the lesion, the scarring, which respects the midline. So this patient had lesions which really affected the upper lid, and you can see the eyelid was damaged. It's remaining open. The eyelid doesn't close. So the cornea becomes exposed. The whole upper part of the cornea becomes exposed, and this leads to exposure keratitis and corneal scarring. So ideally, when you We'll move on to fungal ulcers. So fungal ulcers occur due to trauma to the cornea by vegetative matter. So it happens most of the times to farmers. Most people in Kenya you'll find are farmers, people who come to, let's say they'll come complaining of redness of the eyes and pain. You ask for the history, you'll find that there was history of trauma to the eye by vegetative matter. Maybe they were farming, cutting something in the farm, and something just got into the eyes. What the biggest issue in this case, like I said, with ulcers, is that patients go and get over-the-counter medication which has steroids, and it leads to complete worsening of these issues. It's also common in patients who are immunocompromised. So again, like you see, this is an infiltrate and hypopion in the anterior chamber. So the conjunctiva is injected or hyperemic. You move on to the cornea, which is the next structure. You have the infiltrate. If you can see, you have these extensions from this infiltrate going outwards. So these are called feathery extensions of the infiltrate, and it usually shows a fungal ulcer. In the anterior chamber, we can see the hypopion. This is another patient again with, so this looks like a wreath-like infiltrate, WREATH. The center, there's also the infiltrate. And here you can see a small hypopion. So most of the time, this is an infection with nocardia. So the treatment for fungal keratitis, we use topical antifungals, such as natamycin or amphotericin. And in cases where the infiltrate is big or deep, that is, it's involving more than a lot of the corneal layers, we start them on systemic antifungals, such as ketoconazole or fluconazole. So it's good to note that the treatment will take a long time, at least 6 weeks, unlike the bacterial keratitis, if the infection wasn't very deep. So, but in such cases, so long as you just see that there's an ulcer, start antibiotics. You don't even have to start the antifungals. Start antibiotics and refer the patient to the ophthalmologist. So ACANTHAMOEBA keratitis, it usually has a ring-like infiltrate, and the infection usually commonly occurs in contact lens wearers. It's very painful and is associated with symptoms of photophobia and lacrimation. So it's usually difficult to diagnose, difficult to treat, and in most cases, the patients end up getting having a penetrating keratoplasty done. Like I said, so a penetrating keratoplasty is another term we use for a corneal graft. Remember, keratoplasty is this refers to the cornea, and plasty is the surgery, the graft. So penetrating keratoplasty just means that you remove the cornea full thickness and replace a graft. So as you can see, this is a ring-like infiltrate. When you shine your light, you'll see the infiltrate. Posteriorly, you can see the pupil and the lens is clear. So we'll move on to the non-infectious causes of corneal ulcers. So one, it can either be trauma. Let's say someone was doing something and they were rubbing their eyes, they scratched their eyes, and they cause an epithelial defect. Traditional eye medications, chemical burns, which you'll discuss under the conjunctiva section, I think, with Dr. Gishui. Exposure keratitis, vitamin A deficiency, corneal anesthesia, and Mooren's ulcer. So, traditional eye medicines you can imagine you're instilling something which you don't know, it's likely unsterile, and these patients will use this medication and delay presenting to the clinic. So imagine you've mixed several things, you don't know what exactly it is. It could be acidic, it could be an alkali, and also you don't know, sometimes maybe they'll use heat. So imagine having heat applied anywhere around your eyes, or whatever they instill could have foreign bodies. which will end up scratching the cornea. So these are different images of patients who've had the traditional eye medicines instilled. This is a young child, a baby, who had crushed red brick instilled into the eyes. And you can see it caused this dramatic swelling of the conjunctiva. This is called chemosis. So it really got swollen until it protruded, it sort of everted the upper lids on its own. What can happen is when these traditional eye medicines are instilled, since the patients stay at home, they think they're treating their eyes. By the time they come to see you, you can find that the cornea is already damaged. You can see these are blood vessels coming into the cornea. The cornea should be clear without any blood vessels, but you can see here the cornea has blood vessels. One second. It has blood vessels coming in, and you can see this part which looks black. This means that the cornea is so thin until again the iris is sort of coming, it wants to come out through that area. This is called a desmatocele. Since the cornea is still intact, that means the descemet's membrane, which is tough, is still intact. It's just being protruded outside, being pushed out, and underlying that desmatocele, you have the uveal tissue, that's the iris. So what happens in the end? It leads to scarring of the cornea, and again, loss of vision. So when you get these patients, just treat it like what I had said earlier. Start them on an antibiotic cover, a cycloplegic, and refer the patient to an ophthalmologist. Because most of the times you'll find that they'll end up getting a bacterial infection. So exposure keratitis results from drying of the cornea. So the most common place that you'll encounter this is, let's say, you're in an ICU or a patient who's unconscious. Most people tend to forget about the eyes. If you examine these patients, you'll find that they have poor closure of the eyelids, and the inferior part of the cornea tends to be exposed, leading to an ulcer forming because the epithelium dries out and gets damaged. Then the surface of the eye now becomes vulnerable to infections, and you end up getting scarring at the end of it all. So this is a patient who has the exposure keratitis. This looks like it's active. Then this is when it's starting to scar. So any patient you have who's unconscious or who has difficulty in closing their eyes for various reasons, you need to make sure you actively sort out the eyes. So you can either use ointments or artificial tears to lubricate the eyes. When the patient is sleeping at night, when there's no one like actively maybe putting the ointments and the artificial tears, make sure the eye is strapped. You can use, like in this case, make sure you strap the eye. Bandage contact lenses are also an option. Or we can do lateral tarsorrhaphy. A tarsorrhaphy is where we suture the eye. It can either be permanent or temporary. If it's something which, let's say the patient it's a temporary issue, you can put a tarsorrhaphy, which we just stitch the lateral aspect of the eyelids to make sure that the eye is closed and protected. Then you treat the primary cause. So any patient, remember, who's unconscious, let's say like you're doing ICU duty or you're somewhere, make sure that the eyes are sorted out. Otherwise, the patient will wake up and you'll be very disappointed to find that they can't see well. So like I said, you can use the strapping. You can use this at night to strap the eyes to protect the eye from further damage. This also, even patients who have Bell's palsy, you can also strap the eyes, since in most cases it resolves at least a little bit and it becomes better. So the next is a patient who has Mooren's ulcer. So this is a form of peripheral ulcerative keratitis. The ulcer usually starts from, like I said, the periphery. It's crescent-shaped. And what you notice in this case is that the ulcer has an underlying margin. If you had, let's say, a cotton bud or something which you could lift the margin of the ulcer, you'll find that it's overhanging. Like you lift this part, you'll find that there's a lot of undermining of the edges by the inflammation. So the cause is immunological, and we have benign and malignant types. What happens is, it's like I said, it starts first like a crescent, but it continues slowly to affect the whole. It can affect the 360 degrees, the cornea 360 degrees, and it leads to what is called a contact lens cornea. It ends up looking like you put a contact lens on top of the eye. Then you end up having perforation. If it continues without being managed, you can see in this case so you're told to describe this eye again. Remember, start from the eyelids and the eyelashes. The conjunctiva is injected, and here we have a perforation. So you have a corneal infiltrate here, plus a perforation with prolapsing of the uveal tissue. This is the iris which has come out. And if you shine your torch, you'll see that the pupil is picked towards this area where it is, where it is coming out through the cornea. So this is sorted out by doing a patch graft. So this area is excised. The area of the cornea is excised. A corneal graft is put in place and sutured. The challenge in these cases is that since it's immunological, you'll find the body now, the issue again which was there will continue, and you'll have, in some cases, melting of the graft again. So Mooren's ulcer is very difficult to treat. It involves use of immunosuppressants, prophylactic antibiotics to prevent a superinfection, use of systemic cytotoxic drugs, and in some cases, surgery might be required. So when we do the surgery, you cut, incise the conjunctiva, then you excise it and retract it to move it further away from the cornea, because it's thought that the blood vessels are what delivers the immune, what ends up causing the immunological reaction leading to the ulcers. So in some cases, even you also do cautery to the blood vessels and put a tissue glue adhesive to prevent the conjunctiva from coming too close to the cornea again. This is a case of a patient who the Moorens completely damaged the cornea. Then now the cornea is now covered with scarring and blood vessels. So complications of corneal ulcers, it can lead to blindness, corneal perforation, like in this case, corneal scarring, or endophthalmitis. Endophthalmitis is when now you have the infection going into the inner coats of the eye, the posterior segment of the eye. Remember, I had told you we are handling the structures in the anterior segment. So when it progresses to the posterior segment, it causes endophthalmitis. And in most cases, endophthalmitis, if it's not treated early, the patient ends up losing the eye. You can imagine it's like having a bag of pus. So the eye becomes a bag of pus. So the eye has to be removed. So when you get these patients, try and handle them as carefully as you can to prevent all these things from happening. So the treatment summary, like I said, always start any patient with painful red eyes. Do not start them on any steroid. Anything which has steroids, keep them far away. If a patient, always ask the patient what medication they have used. Ask them if you can see what they have been using. You'll find in some cases they're on steroids like Probita-N. So stop them and start frequent antibiotic drops, such as ciprofloxacin or floxacin. Start it in the first 2 hours, start it every 10 minutes. After that, it should be instilled hourly until they see the ophthalmologist. Then you also give them a cyclopedic for pain, such as atropine twice daily or cyclopentolate 3 times daily. Then refer them to an ophthalmologist. Do not pad the eye at all. If you're sure it's viral and you've seen the dendritic ulcer, start the patient on antivirals. If you're thinking of HZO, always start oral, start the systemic antivirals at the dose which is recommended for HZO. If it's fungal, you start antifungals. If in doubt, always just put the patient on antibiotics, cyclopedic, and refer. So we are done with the class. Does if you have any questions, anything you require clarification, kindly let me know.
Yes, Doc, there's a question in the chat box.
Mm-hmm.
In corneal grafting, where does the graft piece come from? And the unaffected part of the ulcerated eye or the other unaffected eye?
Okay, so in corneal grafting, what happens is that the graft tissue is harvested from someone, because you can't harvest corneal tissue from someone who's alive. So it's always harvested from someone who has passed on. They've given consent, then the tissue is harvested and preserved, then used in cases where it's required. If it's used in a case where the infection is active, it's known as a therapeutic keratoplasty. If it's for a scar, it's known as a just a cosmetic, it's just an optical keratoplasty, because what you're doing is to try and improve the vision. So it's not from the other eye, it's from someone who has passed on, then the cornea was harvested. In some cases, you'll find if the patient, let's say if the patient has a scar around here, the cornea, let's say you don't have access, let's say you don't have access to corneal tissue, and you have the scar in a section which you can rotate the cornea and move the scar away from the visual axis, then that at times can be done, but it's not common. Let's say if the scar is somewhere in this area, and if you rotate it, it will come here away from the visual axis, then at times that is done, a rotational graft, but it's not common. Any other question?
Yeah, there are now quite a few. The other one is, why shouldn't the eye be padded?
You can imagine,
Yes.
you can imagine you have an eye, which, let's say if you have anything, it's like you're creating a good media, a good breeding ground for an infection for the bacteria to proliferate. So when you leave the eye exposed, it's just like, think of like an abscess on the hand, and a wound which has, let's say, debris or something, and you cover it with that debris. What happens? The infection will become, you'll have a lot of you'll have a serious infection. That's why we should not pad the eye which has an infection. I hope I've made it clear.
Yeah, it makes sense. The other question is, kindly clarify the herpes zoster and simplex appearance on the fluorescent stain.
Okay. So what I was saying is, when you look at someone who has herpes simplex, at the end of the dendrite, if it's zoster, okay, if it's like simplex, like in this case, simplex, you'll have the terminal bud, so the dendrite will come, then it becomes round at the terminal bud. But if it's zoster, it has tapered edges. Okay.
Yes.
Yeah. So that's what I was saying. But the key thing you need to just know is, zoster, you'll see the skin lesions. It's respecting a dermatome. They'll complain of tingling sensation in that dermatomal area. Always start the oral antivirals. But in simplex, we start with the topical only.
Mm. Okay, and then
and always remember, acyclovir comes in an ointment form. So don't be asked about treating the viral infections and you say you'll use acyclovir drops. There are other types of antivirals which are in drops, but don't say acyclovir drops, because it comes in ointment form, and it's the most common ointment which is available out there. Yeah.
Okay, someone was asking, what is the success rate for corneal transplants and what is the risk of rejection?
So it depends on the cause why you're doing the transplants. Like in cases where you're doing a transplant for a patient who has keratoconus. Keratoconus is when you have the shape of the cornea changing and becoming conical, and the patient is not able to see, so you do a graft. In those cases, you can even have a 90% success rate. But in cases where you're doing, let's say, a therapeutic graft, like in this case for an infection, worse off if it's ACANTHAMOEBA or if it's a fungal infection, you tend to have a lot of infection again of the graft, rejection. But rejection in corneal grafts is not as much as rejection in other parts of the body, because as you know, the corneas are vascular. So it's not as much as the rest of the body, like let's say when you're doing the kidney transplant and all that. But the risk of the graft failing is, so there's a difference between failure and rejection. The risk of the graft failing is common depending on the cause why you are doing the graft in the first place. But if it's cases where it's just an optical surgery, there's nothing else, if it's associated with it, you can have 90% chances of it being succeeding. Issues again, like viruses like herpes simplex. Remember, it's caused by reactivation of an infection. So what happens is that even if you do the graft, the same infection which was present can come again and infect the graft, because the infection is not arising from the cornea itself. It comes from elsewhere to come and affect the cornea. That's in simplex. So you can imagine you do the graft, the same infection which had come into the cornea can still come again and affect the graft. Yeah.
Okay. Someone is also asking if the cause of the scarring is immunological. Does it mean you'll need to continuously treat with grafts, since clamping blood supply kills the eye?
No, it doesn't kill the eye. Remember, I mentioned for Mooren's. Sorry, I just want to get to. For Mooren's ulcer, you can excise the okay, it's just that this has, let's say it had affected only this section, this part. You would excise the incise the conjunctiva, and then make sure you go two clock hours away this way, 2 clock hours here, then retract the conjunctiva, excise, let's say 4 millimeters away from the cornea, then do cautery of the blood vessels. What you notice is that this cautery, then the blood vessels, it's just a superficial cauterization, and it doesn't, the blood vessels just start flowing again after, in a short while. Let's say like it's not something which will last for long. So it will not cause any damage to the eye. That's why in some cases we still apply tissue glue, which is like super glue, on the surface of the cornea to prevent it from getting even contact with the tears, because even tears have these things which cause the reactions in the eyes. So at times we even use super glue. So just remember, it's the cauterization of the surface of the eye does not make the eye get damaged. And we don't need to treat it with repeated grafts. If at all the patient is not, anyway, the grafts you're doing it because the eye got perforated. Yeah.
Okay. Okay. The other question is, how is hypopion managed?
So when you treat the infection, the hypopion will resolve. So it's just about treating the infection. Frequent instillation of drops to treat whatever is causing the infection, whether it's bacterial or fungal.
Oh, okay. The last question is, for Mooren's ulcer, what immunosuppressant do we use, and are steroids an option in that case?
Yes, so when we treat the Mooren's ulcer, we usually use a step-ladder approach. You first start with topical steroids, and so strong topical steroids such as prednisolone acetate, and topical antibiotics for prophylactic cover, as a prophylactic cover. When we see that the topical steroids are not working, we add on the oral steroids. We start at 1 milligram per kg, then we do the slow tapering of the oral steroids. If this doesn't work, we can now go to the systemic cytotoxic drugs, such as, in most cases we use, we can use like, I think we use cyclophosphamide. So I've mixed up that one. I can't remember clearly, but we do it as a step ladder approach. We don't just start on the cytotoxics immediately. We first start with topical steroids, we go to systemic steroids, then now we go to the systemic cytotoxics. In some places like Kikuyu Eye Hospital, they also have topical cytotoxics which they use.
Right. So, okay, someone is also asking why steroid use is not recommended in most cases.
Because when you use steroids in a patient who has an infection, it will make the infection get worse. In all the cases, whether it's bacterial, whether it's viral, in viral, it will make it become an amoeboid ulcer, and it will cause the eye to perforate. If it's a fungal ulcer, it will become way worse. Like in patients who have allergies, if you're not careful, sometimes they have very bad allergies, they'll have an epithelial defect, and allergies, you treat them with steroids. So if you're not very watchful with these patients, they can get an infection and you don't notice. You continue with the steroids, the eyes get perforated. So
Right.
steroids worsen infections.
Okay, Doc, I think those are all the questions. Thank you so much for this class. It was very interactive, and I mean, it was very detailed, and I'll appreciate if you can please share the presentation with me.
Okay.
Yes.
Thank you. Have a good day.
You too, Doc. Have a good day.
And get well.
Yes.